Hey, future Canadian doctors, welcome to the deep dive.
Yeah,
We're Harvey and Donna,
that's right.
and we're both MCCQE reviewers,
Yeah.
seasoned,
Yeah, season for sure.
who know how tough that exam could be.
It's a bear.
Yeah,
It
it is a
is.
bear.
So we're here to make your review process.
A little bit easier, a little less stressful.
Yeah.
Exactly.
And today we're going to be using some sources like Stat Pearls to really help you understand diabetes mellitus.
Which is a big one.
But yeah, you're bound to see it
Definitely going to see it.
on the MCCQE.
Mm-hmm.
But before we get started, just a reminder,
Yes.
this deep dive is for informational purposes only, and it's not a substitute for real medical advice.
Always consult with a qualified healthcare provider
Yes, always.
if you have any concerns.
Absolutely. So with that out of the way,
Out of the way.
let's jump in.
Yeah, can you remind us what exactly diabetes mellitus is?
Diabetes mellitus.
Yeah, in a way that would impress those MCCQE examiners.
Oh, absolutely.
Yeah.
So DM.
Is essentially a metabolic disorder marked by high blood glucose.
Okay.
And it's a huge global health problem.
I bet.
It affects 1 in 11 adults.
Wow. That is a huge statistic.
This is.
Yeah, and I bet the examiners are going to want you to know the difference
Oh, yeah.
between the two main types, type 1 and type 2 diabetes mellitus.
Yes, you'll probably see those shortened to T1DM and T2DM.
Exactly.
Yeah, so T1DM is an autoimmune disease
Okay.
where the body's immune system attacks the insulin-producing beta cells in the pancreas.
Right.
And no beta cells, no insulin.
Exactly.
And without insulin, glucose can't get into the cells for energy.
Yeah, and this usually shows up in childhood.
Yeah, typically in childhood or adolescence.
Right. But we do see it in adults.
Occasionally, yeah.
But it's important to remember that T1DM patients require insulin therapy, either through injections or an insulin pump,
Absolutely.
to manage their condition.
Right now, T2DM is a bit more complex.
Yes, it is.
It's often a mix of genetics and lifestyle factors that lead to insulin resistance. So the pancreas is still making insulin, but the body's cells aren't responding to it properly.
They're not listening.
They're not listening, yeah.
The body's just like, la, 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 la.
Yeah.
I can't hear you.
Exactly. And so glucose has trouble getting in.
And what's fascinating about this is that over time, that constant struggle to use insulin can actually wear out the pancreas,
It can.
leading to decreased insulin production on top of the existing resistance.
Whoa.
It's a double whammy.
It is a double whammy.
Yeah.
And while we typically see T2DM in older adults,
Right.
it's increasingly showing up in younger folks, too.
Yeah, I think we all know why.
Yeah, likely due to those rising obesity rates.
And those not so healthy lifestyle choices that we all know and love.
Exactly. So speaking of genetics, this is where things get really interesting.
Yes, they do.
Both types of diabetes have a genetic component,
Okay.
but the way it plays out is quite different.
Very different.
Yeah, so with T1DM, it's certain gene variations,
Mm-hmm.
especially in the MHC and HLA genes, that makes someone more susceptible to the disease.
So it's not a guarantee.
It's not a guarantee, but it definitely increases your risk.
It's like having a loaded gun.
It is.
It might not go off,
Right.
but the risk is definitely higher.
Exactly.
Now with T2DM,
Yeah.
the genetic link is even stronger.
Oh, yeah.
Studies have shown that if one identical twin has T2DM, there's a 90% chance that the other twin will develop it too.
90%. 90.
That's huge.
It's huge.
And researchers have pinpointed over 50 polymorphisms linked to T2DM risk.
Wow.
One that's particularly important for the MCCQE
Okay.
is the TCF7L2 gene.
Okay.
Variations in this gene can really increase a person's chances of developing T2DM.
So we've got the genetics down,
We do.
but how does diabetes actually present in a patient?
Yeah, what signs and symptoms should raise a red flag?
Right. Like, what are we looking for?
As future doctors, what are we looking for?
Exactly. Well, there's the classic triad: polyuria, polydipsia, and unexplained weight loss.
Okay, let's break those down.
Okay, so polyuria
Polyuria.
means frequent urination.
Okay.
And it happens because those high blood sugar levels force the kidneys to work overtime,
Oh.
flushing out the excess glucose through urine.
So your body's like, hey,
Yeah.
let's get rid of this extra sugar.
Let's get rid of it.
We gotta pee.
Exactly.
Okay, and all that peeing leads to dehydration,
It does.
which then explains the polydipsia, or excessive thirst.
Yes. The body's just trying to replenish all that lost fluid.
It's just trying to catch up.
It is.
Yeah.
And then there's the unexplained weight loss.
Right.
Since the body can't use glucose effectively for energy, it starts breaking down fat and muscle for fuel.
Not a healthy way to lose weight.
No, not a healthy way at all.
No.
But these symptoms don't always appear together,
Right.
and their intensity can vary.
Right.
T2DM can be sneaky
It is sneaky.
and can hang out in the shadows for years before it's diagnosed.
Like a little ninja?
It is like a little ninja.
Yeah.
Sometimes only revealing itself when complications start to arise.
Yay.
Yeah, so that's why it's so crucial to be aware of these signs.
Be aware.
Consider a patient's history and risk factors, and order those blood tests if you suspect diabetes.
Early detection is key.
It is key.
Okay, so both T1DM and T2DM can share some symptoms,
They can.
but they often present quite differently.
Yes, they do. For instance, T1DM often comes on suddenly hitting hard and fast with those classic symptoms, sometimes even leading to diabetic ketoacidosis or DKA.
DKA, that's a big one.
It is a big one for the MCCQE.
Oh, yeah?
DKA is a metabolic emergency that can happen when the body doesn't have enough insulin
Oh, okay.
to use glucose for energy, so it starts breaking down fat at a rapid rate,
Oh.
producing ketones as a byproduct.
And ketones are acidic,
They are.
so they build up in the blood, throwing off the body's pH balance.
It's a serious situation.
It is.
It requires immediate medical attention.
Definitely.
Now, in contrast to T1DM's dramatic entrance,
Right.
T2DM often develops slowly and gradually, lurking in the background for years before causing any noticeable symptoms.
Like a silent thief.
It is like a silent thief, slowly robbing your health.
It is.
And that highlights why screening for diabetes is so important,
Extremely important.
especially for those over 45 or with risk factors like obesity.
Or a family history of the disease.
Yes, the American Diabetes Association recommends screening for all adults over 75, regardless of risk factors.
Okay.
And for those at higher risk, screening should start even earlier.
Got it.
And those screenings usually involve simple blood tests like the fasting blood glucose,
Okay.
the hemoglobin A1C or HbA1c,
Mm-hmm.
and the oral glucose tolerance test.
Okay.
Each test measures blood sugar in a slightly different way. And there are specific values used to diagnose diabetes and prediabetes.
Ah, prediabetes, another important concept for the MCCQE.
It is.
It's like that warning sign that your blood sugar is higher than normal.
Yeah, but not quite high enough to be diagnosed with full-blown diabetes.
Right. It's that critical window of opportunity to intervene with lifestyle changes like diet, exercise, and weight management.
It's like a yellow light stage where you can still slam on the brakes
You can still turn things around.
and avoid a major crash.
Exactly.
So for those who do progress to a diabetes diagnosis, what kind of long-term complications are we talking about?
Unfortunately, the list is long and can be quite serious.
Oh.
Over time, high blood sugar can damage blood vessels and nerves throughout the body, leading to both macrovascular and microvascular complications.
Okay, let's break those down.
Okay.
Macrovascular complications
Oh, yeah, vascular.
affect the large blood vessels.
Right.
Things like heart disease, stroke, and peripheral artery disease.
Those are the big ones.
They're the big ones. And then microvascular complications involve the tiny blood vessels
The tiny ones.
in places like the eyes, kidneys, and nerves.
And damage to these smaller vessels can lead to a whole host of problems.
A whole host.
Yeah, like for example, diabetic retinopathy as a leading cause of blindness in working age adults.
It is.
It happens when high blood sugar damages those delicate blood vessels in the retina, the light-sensitive tissue at the back of the eye.
It's scary to think that vision loss is a real possibility with diabetes.
It is.
And then there's diabetic nephropathy,
Right.
which affects the kidneys.
Yes. It develops when those filtering units in the kidneys are damaged by high blood sugar.
Okay.
And eventually it impacts their ability to filter waste products from the blood.
And if it's not detected and managed early, this can lead to kidney failure.
Yes, requiring dialysis or even a kidney transplant.
It's really important to emphasize how crucial it is to control blood sugar levels.
It is.
And we can't forget about diabetic neuropathy,
No, we can't.
which is actually a group of nerve disorders that can affect various parts of the body.
Right, we often talk about the impact on the feet.
Yeah, leading to numbness, tingling, and even pain.
Yes, but it can also affect the nerves that control digestion, heart rate, blood pressure, and even bladder function,
Wow.
impacting a person's overall health and quality of life.
So it can really impact a person's life. We've covered a lot of ground here, from the different types of diabetes to the potential long-term complications.
We have.
But the good news is effective management strategies exist.
They do.
So in the next part of our deep dive,
Yes.
we'll explore those management strategies,
Awesome.
including lifestyle modifications, medication options, and the importance of patient education and a multidisciplinary approach to care.
Can't wait.
So stay tuned. Welcome back to the deep dive. We're about to explore how to manage this complex condition,
Yes, we are.
which is super important for both your future patients and for acing those MCCQE questions.
Absolutely. So managing diabetes, effectively, it's like a carefully orchestrated symphony
Okay,
with multiple players working in harmony.
I like that analogy.
Yeah, so let's start with the foundation, those lifestyle modifications.
Okay, so this is where all those healthy habits everyone's always talking about,
Right.
they actually become life-saving interventions.
They do.
We're talking about diet, exercise, and weight management.
The trifecta.
It is the trifecta.
Yeah, and you'd be surprised how many people underestimate the power of these lifestyle changes.
I bet.
They're the cornerstone of diabetes management for both type 1 and type 2.
So important.
It is.
So let's break it down.
It's
First up, diet.
diet.
For those prepping for the MCCQE,
Yeah.
remember that carbohydrate control is key.
Yes.
It's not about eliminating carbs entirely,
No.
but rather choosing complex carbs over those sugary refined ones.
Exactly. And don't forget about healthy fats.
Oh yes, healthy fats.
They play a vital role in blood sugar control and overall well-being.
They do encourage your patients to opt for unsaturated fats found in foods like avocados, nuts, and olive oil.
Good stuff.
It is good stuff.
Yeah.
Okay, so we've got the diet part down.
Check.
Now let's get those bodies moving.
Let's get moving.
Regular exercise is a must for anyone with diabetes.
Yes.
Aim for at least 150 minutes of moderate intensity aerobic activity per week,
Like what?
like brisk walking or cycling.
Oh, okay. I can do that.
You can do that.
Yeah. And don't underestimate the power of strength training a couple times a week.
Oh yeah, strength training.
It helps improve insulin sensitivity and builds muscle mass, which is beneficial for blood sugar control.
Absolutely. All right, so we've covered diet and exercise. What about weight management?
Okay, so for those who are overweight or obese, even a modest weight loss of 5 to 10% can make a significant difference
Wow,
in improving blood sugar control and reducing the risk of complications.
that's huge.
It is huge.
So it's not about achieving some unrealistic ideal weight,
Right.
but rather making those sustainable lifestyle changes that
Exactly.
can lead to healthy, gradual weight loss.
I like it. So we've got diet, exercise, weight management, all those lifestyle things.
Yes?
Now, while lifestyle changes are the foundation, medication often becomes necessary.
Right, especially for those with type 1 diabetes who don't produce any insulin.
Right. In these cases, insulin therapy is essential either through multiple daily injections or a continuous insulin pump.
And the choice between injections and a pump depends on individual needs and preferences.
It does, and it's something you'll discuss with your patients as their doctor.
Absolutely. Now, for type 2 diabetes, there's a whole arsenal of medications, both oral and injectable, that can help manage blood sugar levels.
We've got options.
We do. And this is where the MCCQE can get tricky
Oh, yeah.
with all those different drug classes and mechanisms of action.
So many drugs.
So many drugs, so many mechanisms.
Don't worry, we'll break it down.
Okay, good.
Let's start with metformin, a big one-eyed.
Okay, metformin.
It's often the first-line treatment for type 2 diabetes because it's effective, well-tolerated, and relatively affordable.
That's great. How does metformin actually work?
Okay, so it has a multi-pronged approach.
Multi-pronged.
It improves insulin sensitivity, helping the body use its own insulin more effectively.
Okay.
It also reduces glucose production in the liver and slows down the absorption of glucose from the gut.
So it tackles high blood sugar from several different angles.
It does. It's pretty impressive.
It is impressive. Are there any side effects to be aware of?
The most common ones are gastrointestinal,
Okay.
like nausea and diarrhea.
Okay.
And it's super important to remember that metformin can, in rare cases, cause lactic acidosis,
Lactic acidosis.
a serious condition.
Is.
And this is particularly important to keep in mind if your patient has kidney issues.
Good point. So monitoring kidney function is key when prescribing metformin.
Yes, it is.
Now let's move on to another class, sulfonylureas.
Okay.
They work by stimulating the pancreas to release more insulin.
Okay. Examples of sulfonylureas include glipizide and glyburide.
Okay.
And while effective, they can sometimes cause low blood sugar or hypoglycemia.
Well, hypoglycemia, another potential pitfall of diabetes management,
It is.
and a favorite topic for the MCCQE.
Oh, for sure.
Can you remind us what happens during a hypoglycemic episode?
Of course, hypoglycemia occurs when blood sugar levels drop too low.
Okay.
And the brain, which relies heavily on glucose for fuel, it starts to malfunction, leading to a range of symptoms.
Like what kind of symptoms?
You might see shakiness, sweating, weakness, dizziness, confusion, difficulty concentrating,
Wow.
headache, blurred vision,
Okay.
and even hunger and irritability.
How many?
In severe cases, it can lead to seizures, loss of consciousness, and even coma.
That sounds serious.
It is a real medical emergency.
What should you do if you suspect someone is experiencing hypoglycemia?
Okay, so if the person is conscious and can swallow, the best thing to do is give them something sugary to raise their blood sugar fast.
Okay, like what?
Think fruit juice, regular soda, not diet,
Okay.
glucose tablets, or even hard candy.
So those quick-acting carbs we talked about earlier.
Exactly. Aim for about 15 to 20 grams of carbohydrates initially.
Okay.
Then recheck their blood sugar in about 15 minutes.
Okay.
If it's still low, give them another dose of quick-acting carbs.
And if the person is unconscious or can't swallow?
Call 911. Immediately, they may need glucagon,
Glucagon.
a hormone that rapidly raises blood sugar, usually given by injection.
So glucagon is like that emergency rescue medication.
Precisely. It's crucial for people with diabetes, especially those on insulin,
Okay.
to have a glucagon kit handy and to teach their family members or close contacts how to use it.
That's a great point. Now back to those medications.
Yes, back to the drug.
We've covered metformin and sulfonylureas.
We have.
What other classes are out there that our listeners should be familiar with for the MCCQE?
Okay, well, we have the meglitinates,
Meglitinids.
which are similar to sulfonylureas in that they also stimulate insulin secretion,
Okay,
but they're shorter acting, so they carry a lower risk of hypoglycemia.
that's good.
It is.
What else?
Then there are alpha-glucosidase inhibitors, like acarbose.
Alpha-glucosidase inhibitors.
They work by slowing down the absorption of carbohydrates from the gut,
Okay.
helping to prevent those after-meal blood sugar spikes.
So they're all about controlling those post-meal highs.
Exactly.
What about the thiazolidinediones or TZDs?
Okay, so TZDs enhance insulin action in the body's tissues,
Okay.
but they come with some baggage.
Uh-oh.
Fluid retention, potential heart problems, and even bone fractures.
Wow.
So they're not used as often these days.
So they're a bit riskier.
They are.
Are there any newer medications for type 2 diabetes that show more promise?
Absolutely. GLP-1 receptor agonists and DPP-4 inhibitors are two newer classes that are quite popular right now.
What makes these classes so special?
They offer good blood sugar control, and they come with a lower risk of hypoglycemia compared to some of the older medications.
That's great to hear. Are there any specific examples of these newer medications that our listeners should know for the MCCQE?
Definitely examples of GLP-1 receptor agonists include medications like liraglutide and semaglutide.
Okay.
They work by mimicking a naturally occurring hormone called GLP-1, which helps the pancreas release the right amount of insulin after meals.
It's like a smart assistant for the pancreas.
Exactly. And what about DPP-4 inhibitors?
DPP-4 inhibitors.
Sitagliptin and saxagliptin are two common examples.
Okay.
They work by blocking an enzyme called DPP-4, which breaks down GLP-1. By inhibiting this enzyme, they essentially boost the levels of naturally occurring GLP-1 in the body,
Okay.
leading to better blood sugar control.
It's amazing how these medications can work with the body's natural systems to manage blood sugar.
It's pretty cool.
It is pretty cool. Now, you mentioned another exciting development, SGLT2 inhibitors.
Ah, yes. SGLT2 inhibitors are like the superheroes of diabetes medications.
Okay.
They work in a completely different way than other drugs,
How so?
by increasing the excretion of glucose through the urine.
Wait, so they actually remove excess glucose from the body?
They do.
That's incredible.
It is, and on top of lowering blood sugar, they've also shown remarkable promise in improving cardiovascular and renal outcomes in people with type 2 diabetes.
So they're protecting the heart and kidneys as well.
Exactly. Some common examples of SGLT2 inhibitors include canagliflozin and empagliflozin.
Okay.
They're definitely worth knowing for the MCCQE.
It's clear that there have been some major breakthroughs in diabetes treatment.
There have.
But remember, medication is just one piece of the puzzle.
It is. Living with diabetes requires a holistic approach, a team effort involving not only the patient,
Right.
but also healthcare providers from various disciplines. We're talking doctors, nurses, pharmacists, dietitians, ophthalmologists, podiatrists, and even mental health professionals.
So it's a true multidisciplinary approach.
Exactly. Each specialist brings their unique expertise to the table
Okay.
to help patients navigate the challenges of diabetes and live their best lives.
And patient education is paramount, right?
Absolutely. Empowering patients with knowledge about their condition, self-monitoring techniques, and healthy lifestyle choices
Okay.
is crucial for successful long-term management.
It's all about giving them the tools and support they need to take control of their health.
It is.
Well, we've covered a ton of information about managing diabetes.
We have.
In the final part of our deep dive, we'll delve into those specific long-term complications in more detail, exploring how they're diagnosed, treated, and most importantly, how to prevent them.
Can't
So stay tuned. Welcome back to the deep dive. In this final part, we're going to go deep into those long-term complications of diabetes that we touched on earlier.
Yes, these are the challenges you as future doctors will need to know how to spot, how to treat, and hopefully how to help your patients prevent altogether.
Exactly. High blood sugar can be sneaky, quietly, causing damage to blood vessels and nerves throughout the body.
Right, and this can lead to some serious issues if it's left unchecked.
So let's start with diabetic retinopathy. We know it's a leading cause of blindness in working-age adults. But what's actually happening in the eye to cause this?
Okay, so imagine the retina, that light-sensitive tissue at the back of the eye, as a delicate tapestry of tiny blood vessels.
Okay.
When blood sugar is consistently high, it's like spilling sticky syrup on this tapestry,
Oh.
damaging those delicate threads.
Okay, I can picture that. So how does this damage actually lead to vision loss?
Well, in the early stages, those damaged vessels might leak fluid or even bleed, causing blurred or distorted vision. Sometimes people don't even notice these subtle changes, which is why regular eye exams are so crucial for anyone with diabetes.
So it's all about catching it early. What happens if those early warning signs are missed?
If left untreated, those damaged blood vessels can actually close off, completely starving parts of the retina of oxygen.
And that's bad news for those retinal cells.
It is, and in a desperate attempt to survive, the retina tries to grow new blood vessels. But here's the catch. These new vessels are often weak, leaky, and prone to bleeding, causing even more damage.
So it's a vicious cycle, and what happens if this cycle continues unchecked?
In the worst-case scenario, those abnormal blood vessels can lead to retinal detachment or glaucoma, both of which can cause permanent vision loss.
This all sounds pretty grim. Are there any effective treatments for diabetic retinopathy?
Absolutely. The good news is we have some powerful tools in our arsenal in the early stages. Tight blood sugar control and managing blood pressure can often slow down the progression.
So those healthy lifestyle choices and medication adherence we talked about earlier really come into play.
They do, but for more advanced cases, we might need to bring in the big guns, laser therapy or injections of medications directly into the eye.
Laser therapy sounds intense. What does it actually do?
It's actually quite precise. A focused beam of light is used to seal off leaky blood vessels or destroy those abnormal fragile ones,
Okay.
preventing further damage to the retina.
And what about those injections? What kind of magic potion are we putting in there?
We call these medications anti-VEGF drugs. VEGF stands for vascular endothelial growth factor,
Okay.
which is a protein that promotes the growth of new blood vessels.
Okay, so these medications are like tiny construction workers going in and putting a stop to the building of those unwanted leaky vessels.
That's a great way to think about it. These injections have revolutionized the treatment of diabetic retinopathy, helping to preserve vision for countless people.
That's incredibly encouraging to hear. So it is possible to live a normal life with diabetic retinopathy.
Absolutely. With early detection, diligent management, and the right treatment, many people with diabetic retinopathy can maintain good vision and lead full, active lives.
That's a relief. Now let's shift gears and talk about another serious complication, diabetic nephropathy. It affects the kidneys, right? Those incredible filtering units that keep our blood clean.
Exactly. Remember, the kidneys are like a complex network of tiny blood vessels filtering out waste products from the bloodstream. High blood sugar, unfortunately, can damage these delicate filters.
And how does this damage actually manifest? What should we be looking for in our patients?
One of the earliest signs is something called microalbuminuria. It's a fancy way of saying that small amounts of protein are leaking into the urine,
Okay.
a telltale sign that those kidney filters aren't working as well as they should be.
So the simple urine test can reveal a lot. What happens if we miss this early warning sign?
If left untreated, the damage progresses and you start seeing larger amounts of protein in the urine.
Okay.
This is called macroalbuminuria, and it indicates more advanced kidney damage. Eventually, the kidneys become less and less efficient at filtering waste products, and that's when things get really serious.
So kidneys start to fail.
Unfortunately, yes, and ultimately this can lead to end-stage renal disease, or ESRD, which means the kidneys are no longer functioning well enough to sustain life.
That's a scary thought at that point. What are the options?
The patient would need dialysis or a kidney transplant to survive. It's a life-altering situation that highlights the importance of early detection and aggressive management of diabetic nephropathy.
Okay, so we know regular screening for kidney problems is crucial for anyone with diabetes. What does that screening look like?
It's actually quite simple. Urine tests can detect that protein leakage we talked about, and blood tests can assess overall kidney function.
And what can we do to slow down or even prevent the progression of diabetic nephropathy?
Again, it comes back to those cornerstones of diabetes care. good blood sugar control and blood pressure management, and certain medications that lower blood pressure, especially those that block the renin-angiotensin system, have been shown to be particularly protective for the kidneys.
So it's a combination of lifestyle changes, medication adherence, and regular monitoring. Early intervention is key.
Exactly, the sooner we catch and treat diabetic nephropathy, the better the chances of preserving kidney function and preventing those life-altering complications down the road.
All right, we've covered the eyes and the kidneys now. Let's talk about diabetic neuropathy. This one's all about nerve damage, right?
That's right, and it's not just one type of nerve damage, but rather a whole group of nerve disorders that can affect various parts of the body.
We've already talked about the dangers of diabetic neuropathy in the feet, leading to numbness, tingling, and pain. But you mentioned it can impact other areas too.
Absolutely. It affects the nerves that control digestion, leading to nausea, vomiting, diarrhea, or constipation. It can affect the nerves that regulate heart rate and blood pressure, making it harder for the body to maintain a stable internal environment. And it can even affect the nerves that control bladder function, leading to urinary incontinence or difficulty emptying the bladder completely.
Wow. So diabetic neuropathy can really wreak havoc on multiple systems.
Yeah.
The symptoms sound pretty awful too.
They can be, we're talking about burning pain, sharp stabbing pain, even a feeling of electric shocks running through the limbs. It can be very debilitating and significantly impact a person's quality of life.
Is there any way to stop or reverse this nerve damage?
Unfortunately, there's no cure for diabetic neuropathy, but don't worry, we're not completely powerless. We can manage the symptoms and slow down the progression.
And I bet good blood sugar control is at the top of that list.
You know, preventing further nerve damage is all about keeping those blood sugar levels within a healthy range. And when it comes to managing the pain, we have various medications at our disposal, including antidepressants, anticonvulsants, and pain relievers.
So it's a tailored approach, finding the right combination that works for each individual.
Exactly. And it's not all about pills and potions. Non-medication approaches like physical therapy, acupuncture, and transcutaneous electrical nerve stimulation or TNS can also be very helpful for some people.
It sounds like it's all about empowering patients to take an active role in managing their neuropathy, exploring different options, and finding what works best for them.
Couldn't have said it better myself. And remember, managing diabetic neuropathy is an ongoing journey requiring close monitoring, regular follow-up with their healthcare team, and adjustments to their treatment plan as needed.
Well, Donna, we've explored the depths of diabetes mellitus, from the basic mechanisms to those complex long-term complications. I bet our listeners, those future doctors out there, are feeling a lot more confident about tackling this topic on the MCCQE.
I hope so. It's been a pleasure diving deep into this crucial topic with you.
And remember, while diabetes can lead to some serious challenges, it's by no means a hopeless diagnosis with early detection. A commitment to healthy habits and the right medical care, people with diabetes can lead long, fulfilling lives.
And you, our listeners, will be equipped to guide them on that journey, using your knowledge and compassion to make a real difference.
That's what it's all about. So keep those brains engaged, keep asking those insightful questions, and keep striving to be the best doctors you can be. We'll catch you on our next deep dive, where we'll tackle another fascinating medical mystery together.